All right. Yeah, so I'm going to start off tonight by talking about contact lenses. So we'll be talking about different soft contact lenses and hard lenses as well. So first of all, why do patients like to wear contact lenses? The main reason is really going to be for cosmetic purposes. Some patients just really don't like wearing glasses on their face. They don't like how they look, and they prefer to wear contacts to correct their vision. They're really awesome to wear if you have a very active lifestyle, play a lot of sports, that type of thing, where glasses just aren't as ideal. They can increase the field of view. So when people wear glasses, part of their view is blocked by the physical frame. And when you wear contacts, that increases the field of view that way. There could be improved visual quality. Usually that's better with hard lenses compared to soft, and we'll kind of talk about that a little bit later on. But you can get really great visual quality with hard lenses. There's a natural image size that's provided. If you imagine somebody who is, really myopic, and when you're just looking at them through their glasses, you can even tell by how their eyes look very minimized and small. And that's the same for when they're looking through those same lenses. With a very myopic person, their whole world looks super small by looking through glasses. Same with hyperopia. Instead of minimized, it's magnified. Their eyes look big and things just look a lot larger through glasses. When you have contact lenses, you don't have to deal with any minification or magnification. And then contacts can also be used as a therapeutic device, things for like dry eye, correcting keratoconus, things like that we'll talk about. So first, we'll start with soft contact lenses. So the different ones out there are going to be your commercials, softs, custom softs, and specialty softs. Commercial soft lenses are going to be, your run-of-the-mill, off-the-shelf contact lenses that a lot of people wear, including myself. So these will be your daily lenses, your biweeklies, your monthlies, those type of things. They come in, a wide range of parameters, but can only go up to so much in the parameter. They can correct hyperopia, myopia, astigmatism, and there's even some multifocals. And I just listed some of the major companies out there that you'll see. They're usually made up of silicone hydrogel material, which have great comfort and have a good oxygen permeability. So they're really good for patients that just need good correction there. Custom softs are going to be, very customizable. We can have a very specific power. It can go a lot higher in parameters than our normal commercial softs. They can be put at a specific axis and a very specific, astigmatism. We can adjust the size of the contact, the base curve, all types of different things. Here in Fargo, we like to use them for prosthetic purposes, meaning some patients who have like iris atrophy or something like that, we can, match the color in their other eye for cosmetic purposes there. Or if somebody has like super light sensitive in one eye from like an abnormal pupil or something like that, we can actually use the contact and adjust the pupil so it looks more normal and to increase or better light sensitivity with that. So again, these are good for patients who have a very high refractive error, have smaller, larger eyes, steeper flat corneas, and again, those iris or pupil abnormalities. We can really customize it however you want. Specialty softs are a little different. These are going to be for patients who have an atypical cornea shape. So things from like keratoconus, or if they've had a previous corneal transplant or something like that. I will say, and we'll talk about pretty soon here, that hard lenses or gas permeable lenses are going to be better for these types of patients. But these are good for if the patient, is intolerable, has a tolerance to hard lenses, or they struggle with the insertion removal, or something like that. The soft lenses also provide some vision correction for these patients. So moving on to our gas permeable lenses, these are going to be our hybrid lenses, our corneal GPs, or reverse GPs, and our scleral lenses. So why would we pick a hard lens over a soft lens? So kind of what I said earlier, hard lenses provide really, really good optical quality and clarity. And the reason why is the hard material itself is able to mask any sort of corneal irregularities that a soft lens cannot. And by masking that, it corrects astigmatism, corrects, scarring, that type of thing. And it just creates like almost like a new smooth surface for the cornea and makes the power easier to get and just great optical quality. There is improved ocular health with hard lenses. There's a special tear layer and good oxygen that is provided. So there's improved ocular health compared to a soft lens. They're super durable. Most of these, if you take really good care of them, can last a year or two, or sometimes 3 years if you're taking, really good care and not abusing them or dropping them or, anything like that. They're also super customizable, kind of like the custom softs there. Fitting process for most hard lenses can either be empirical or diagnostic. Empirical means kind of just gathering data like the patient's K values, their manifest refraction, their HVID, things like that. And then we are able to send that to a lab, and then the lab just sends a lens back based on those parameters. Diagnostic is a little different. This is when there's physical fitting sets of different contact lenses. So here we have a bunch of hybrid and scleral fitting sets that have like 10 or 15 lenses in them. And basically what you do with the diagnostic is you put, one, two, three, or four lenses on the patient's eye, and you kind of pick and choose what you like most about each lens. And then based on what you think there, you tell the lab, I like this out of this out of this lens, and then they're able just to customize and send that lens for you. Different coatings and materials can be put on hard lenses for like dry eye and comfort. Main disadvantages are going to be, it is a hard lens, not a soft lens, so there is some initial discomfort right away, kind of getting used to the lens. The cornea does have a lot of nerve endings on it. So if you can imagine, it just right away feels like there's just something constantly in your eye. But as the patient wears it more and more and more, they're able to adapt quite well to it. And usually these lenses are more costly than our soft lenses up front. And sometimes the fitting process itself can take a little bit longer than a soft lens by, having to order, and it takes a little longer for the lenses to come in, and if we have to tweak or do anything of that nature. So hybrid lenses, a hybrid lens has a mix of a hard hard contact with a soft contact. So in the center is going to be that RGP or that hard lens, providing the optics there. And the outside is going to be more like a soft contact lens or a soft skirt. So advantages are going to be the really good optical quality by, again, masking the corneal irregularities with the RGP. And they're a little bit more comfortable with a soft contact. They're good for irregular corneas, correcting astigmatism, and you can put multifocal optics in there. It can't implement something called a front toric. A front toric is basically just adding in extra astigmatism correction into the lens itself. So, it masks the cornea and that type of astigmatism. But if there's astigmatism coming from within the optical system, like in the intraocular lens, that unfortunately cannot be corrected in a hybrid lens. Corneal GPs, these are going to be a little smaller than the normal soft lenses, and they're fully just the hard lens material. With RGPs, you probably don't need to know as specific in detail as this, but one thing to note is that RGPs create something called a tear layer. And so the RGP itself doesn't sit directly onto the cornea. When it goes on the eye, it creates a tear layer in between that and the cornea. And this tear layer actually has power. So there's going to be three spots where that you have to take into account when you order lenses with a certain power for these. So the power comes from the tear layer, the cornea itself, and the contact lens. And kind of to think about a little bit differently. Simply, there's three ways that you can fit or create a tear layer, and each manufacturer for different GPs does it a little bit differently. On-K just means that the cornea, or excuse me, the tear layer curvature is exactly the same as the contact lens curvature. And when they're exactly the same curvature, then it creates a zero power. If you fit the contact in something called steeper than K, that just means that the contact lens base curve is steeper than the keratometry value, which keratometry we'll talk about a little bit later. But when it's fit steeper than that, it actually creates a plus tear film underneath the contact lens. So now we're introducing new plus power into the system. And then vice versa, if you fit a little flatter than K, you're creating a minus tear layer with minus power. So there's this acronym called SAM-FAP, which is steeper add minus, flatter add plus. So for example, if you fit a GP that's steeper than K, again, it creates that plus tear film. And so steeper add minus, because you're creating a plus tear film into the contact lens itself, you have to add minus power into the contact to counteract that plus power. If you didn't do that, then the patient would be, uncorrected, having extra hyperopia or extra plus power that they don't need, and it'll cause blurry vision. So you do have to add and counteract minus power with a steeper lens. And then same thing with flatter lens. To counteract the minus power that's created, you have to add plus power into the contact lens when you order it. GPs you can add in different astigmatisms in there, or astigmatism correction. And then you also can do multifocal. With multifocal, there's two ways that you can do it. There's translating and simultaneous designs. Simultaneous is kind of like your soft contact lens, or if you think of like a multifocal IOL where there's little concentric rings, and as you're looking, distance and near, your brain is able to kind of adapt and look where you need to. Translating is a little bit different. Translating, you kind of think of it as like a line bifocal in a way, where the patient, as they look down, their lower lid actually is able to push that contact up a little bit, and in that bottom part of the contact, there's extra add power, and that's how they would read. Reverse GPs, are exactly the same as our corneal GP, but these ones are actually worn at nighttime while the patient is sleeping, very commonly used in orthokeratology or ortho-K. And you'll hear this commonly with something with myopia control or myopia management. So myopic children, when we want to, slow down the progression of their myopia, wearing ortho-K lenses at night are a great option for them. They're also, good for adults as well. If the patient just doesn't want to have to deal with contact lenses during the day, they can wear them at night and correct their myopia, and then they're good to go for the day. So great for patients with active lifestyles, or if they do a lot of swimming or work in dusty, dirty environments. And these are going to be best in patients who have, normal corneas and nothing too crazy like keratoconus or something like that. These do come into certain parameters. If we're talking about a person who has like 8, 9, 10 diopters of myopia, it's probably not going to be the best. So these would be for, our -6s and below, and you can put some astigmatism correction in them. And how the technology kind of works is, if you can kind of see the little bullseye pattern here. So in the center, the lens itself is fit pretty flat. And when it's fit really flat, it pushes on those tear layer or those epithelial cells, and it creates this pressure gradient to move those cells into the mid-periphery. And by doing that, it kind of reshapes the eye or that tear layer in the front, and it corrects their vision that way. Over time, throughout the day, the eye is able to kind of bounce back and regress. So most patients, you want to get at least a good 8 hours if you can, 6, 7, 8 hours of sleep with these lenses in to provide all day correction. And then usually towards the end of the day, things might start getting a little bit blurrier. But yeah, these are great for correction or for myopia control. And if you have any, other questions on myopia control, I'm happy to go over that. That can be a whole nother tech training thing, so I won't go too much into it, but. And then lastly is going to be scleral lenses. So we do a lot of scleral lenses here in Fargo, and I think they do that in Sioux Falls as well. Scleral lenses are a little bit different than your GPs in where the material itself is still a hard material, but they're a lot larger than the corneal GPs. And instead of sitting and creating a tear layer, they actually vault over the entire cornea and they land on the white part or the sclera of the eye. And to put in the lens, there's some plungers involved with them. You fill it and create a fluid reservoir by putting preservative-free saline into the bowl, and then it's put onto the eye. And it does the same thing by negating corneal irregularities. And these are great for patients who have keratoconus or, post-transplant patients. These are great for patients who have extremely dry eye that have tried like a lot of drops and everything and are just kind of tired of it. And if you can imagine for dry eye, with the scleral lens or the eye is kind of sitting in just a pool of saline all day. So it's really nice for dry eye and it can correct high refractive errors. And again, the biggest thing with scleral lenses are they are really large lenses and kind of the insertion removal can be a little daunting at first just with all the plunging that's involved. But once you get it, it's pretty easy. Probably don't need to know too much about this, but when we're looking at scleral lenses, there's a lot of different customizations that, I'm looking at or that doctors are looking at with the lenses. The fluid reservoir changes a little bit whether we're looking at the center of the eye versus the mid-periphery versus the limbal area. But basically all we're checking is that there's adequate fluid reservoir or adequate, fluid covering the entire cornea because we don't want to see that the lens is touching the cornea at any point. We want to make sure that it's vaulting over the entire cornea. When we're looking at the landing zone, we want to make sure that the edges of the lens aren't, squeezing the eye too much or not lifting up too much. We want to make sure that it's nicely landing onto that sclera. With scleral lenses, you're going to have very minimal movement. And then we also check for making sure that the lens is centered and rotated adequately. Just kind of a quick example here. This top right photo, you can kind of see that the edge of the lens here, we call this impingement or blanching. It's squeezing too hard on the lens or on the sclera where it's actually constricting some of the blood vessels there. So we see this white band followed by the normal red pigment of the conjunctiva. Below here would be a better fit of the lens. We don't see a lot of impingement or compression of those blood vessels. There's different disinfectant and solutions that are used for all of the contact lenses that I talked about. Multi-purpose is going to be your OptiFree or your BioTrue. These are good for cleaning and storing soft lenses. They could also be used for kind of rinsing off some of the hard lenses. We do not want to use these multi-purpose to fill a scleral lens bowl. Disinfectants are more used for our gas permeables or hard lenses. We use a lot of what's called Boston Simplus here, and these just clean the lens a lot better, and then they can be stored overnight in these. And these are just some different brands that you can use. Oxidative systems, this is going to be your hydrogen peroxide. These can also be used for any of the lenses that we talked about. These give a really good clean of the lens. So if a patient, is having trouble with fogging of lenses or just getting a lot of debris on their lenses for some reason, the ClearCare hydrogen peroxide gives a nice good clean. One thing I wanted to note with it is that you do need to soak the lenses for at least 6 hours to neutralize. And neutralize is, it's kind of like a chemical reaction where it's safe to then wear the lenses afterwards. If you don't wait 6 hours and you put them in at like 2 or 3 hours after soaking, and put them on the eye, it's gonna create like a chemical burn with that hydrogen peroxide, and we do not want that to happen. It can be very painful, so we do need to make sure we're waiting that 6 hours. And for certain coatings, you don't want to use it. This is kind of more so for the colored contacts. It can kind of strip the coating there. Filling solutions, this is what's used for our scleral lenses. The eye is going to be sitting in that solution, all day. So we want to make sure that it's preservative free and not multi-purpose. If there's preservatives in it over time, that can create an allergy and irritation and some blurry vision. And then these are just some examples of some salines that we use. This is just a chart showing when you're doing like diagnostic fitting sets that we talked about before. As you can imagine, we're using these same lenses on multiple patients, so we need to make sure that we're using the right protocol to clean the lenses in between patients, so we're not, spreading infections or doing anything like that. So these are just some the protocols to do that. I think I have enough time here to go over a couple complications. So with contact lenses, the main time you're going to see complications are when patients are abusing their lenses or sleeping in them and showering in them and doing all the things that you should not do with contacts. Um, Fogging is not one of those things. Fogging is a common complaint in scleral lens patients where debris just kind of enters that bowl of the chamber. How we fix that is we need to make sure that the fit is accurate and that there's no, loose edges of why debris would be filling up in there. Dry eye can cause fogging. Sometimes just as easy as switching the filling solution of the scleral lens can help with fogging. And sometimes, if you tried, switching the solution, making sure the fit is good, sometimes patients still just continue to fog, and sometimes they just need to take out their lens and refill it and do that once or twice a day. Contact lens acute red eye or glare. This is kind of an inflammation response to sleeping in your contact lenses overnight. Patients will sleep in their lenses, they'll wake up and their eye will be painful, light sensitive, injected. They'll tear up a lot. Um, and again, it's mainly from sleeping in the lenses. Main treatment is just to stop wearing the lenses. You can just use artificial tears, or you can use a steroid to kind of speed along the healing process there. Neovascularization, again, this is from sleeping in lenses multiple times, and it creates a corneal hypoxia or decreased oxygen. And when there's decreased oxygen, the body likes to respond to that by growing new blood vessels, and these blood vessels should not be on the cornea. If we see this, sometimes it can lead to thinning, it can lead to scarring, it can lead to decreased vision, all not great things. So again, it's either switching contact lenses, educating the patient, treating with steroids, that type of thing. GPC or giant papillary conjunctivitis is when the eye kind of almost has like an allergic response to the contact lenses. We'll see very large papillae on the upper conjunctiva there. The eyes will seem puffy, itchy, irritated. And again, it can be just a reaction to the edge of the lens. It can also be from abusing the lenses, that type of thing. So how we treat that is with steroids usually. We can try antihistamines, Pataday. Those are all great drops for that. Last two here, sterile corneal infiltrates are another inflammatory process. What we see here are kind of clumps of white blood cells that look kind of white or gray in appearance. They're usually on the peripheral or mid-peripheral side. And again, these are from sleeping in the lenses and creating this hypoxic environment of the cornea. And then the body of the eye kind of responds by having this inflammation response. Usually, again, these are going to be fixed by steroids and proper education, and even sometimes switching the lens material. Microbial keratitis is going to be, the worst thing that can happen by sleeping in the contacts. This is a true bacterial, fungal, or protozoal infection from abusing contact lenses. It's extremely painful. Patients are, uncomfortable. They can't see, and it's very sight threatening. And this is the worst of the worst infection that you can have from sleeping in lenses. So again, it's always starts with good education on with our patients and letting them know that you should not sleep in the lenses and stuff like that. These patients need usually like fortified antibiotics. We culture it and see what the infection truly is and treat it from there. But usually these scar pretty good, and sometimes we can't get vision back to where it was before. So it's probably, the scariest one to deal with there. And that's all I got. And I'm going to switch it over to Dr. Morales here now. go ahead and stop sharing. Happy to answer any questions if anybody has any too.
Thank you so much, Dr. Nelson. That was really good. Don't sleep in your contacts and don't rub your eyes.
Couldn't agree more. Good, wise advice. All right, let me just get um, my view set up. So just give me one moment here.
Yep, no problem.
Make sure I have the right presentation. Let me stop share for just 1 second.
All right, we're able to see your slides.
Great. I'm gonna make that a little bit larger here. Um,
Perfect.
do you see a presenter view here
And
or?
we're just seeing the slides, so not the presenter view. So
Okay,
yeah,
great.
we're all set.
Awesome. So I'll talk a little bit about the cornea, specifically like keratometry, which is kind of like the way to measure the cornea in different ways. So we'll start with some refractive astigmatism. What that means is the total astigmatism or the total amount of astigmatism corrected for. And so this can come from two places for a patient anatomically. Typically, it's the cornea and the lens that we're thinking about. Um, the lens astigmatism kind of changes as you have birthdays and get a cataract, and so that will contribute to some mild astigmatic changes. But typically the cornea is a big driver of astigmatism for patients, and that's kind of maybe the type of astigmatism that you hear patients talk about when they're like growing up. They're like, oh yeah, I have astigmatism. They're usually probably referring more to their cornea. You can have some like lens changes early on, but it's a little less common. And so an example of how we would write a refraction is kind of listed here with the sphere as the first number and then the cylinder and the axis. And so here, the refractive astigmatism is -1, which is indicated by that cylinder notation. Um, and so then we'll talk a little bit about axis in just a couple of slides here. So corneal astigmatism is the amount of astigmatism that's due to the shape up and power that's present on the cornea. And we have two types, regular and irregular. And I will show an example of astigmatism in just a slide here, but regular just means that there's two like meridians that have symmetrical like power that we can measure. And they're typically about 90 degrees apart. And that's really the most common type of astigmatism, and certainly the easier type of astigmatism to correct. Irregular astigmatism means that these meridians are not 90 degrees apart, and this can happen for a variety of reasons. We think of like keratoconus, patients who are like post-refractive, who maybe had a little bit of an unusual like healing response. If they have scarring, that can certainly create irregular astigmatism. And Dr. Nelson was just talking about like patients who get contacts lens associated ulcers. They can have scars that kind of create irregular astigmatism, and that can be a little bit tougher to treat. And then trauma. So if patients had any like sutures on their cornea or like a scar on their cornea from trauma, that can create some irregular astigmatism. What to kind of put a picture to astigmatism. So for people who don't have astigmatism, the shape of their cornea is more like a soccer ball. If you were to kind of slice it in half and then put it on the front of the eye, that is what kind of like a regular cornea would look like that doesn't have any astigmatism. Versus someone who does have astigmatism, they would have one part of their cornea that's a little bit smaller in radius, and then another part that's a little bit like a little bit of a larger radius. And so the on this picture here with the football, it's a good example. So kind of vertical meridian that we're looking at with that red line is actually a more powerful cornea-like measurement than the blue line, which is less powerful because the radius of curvature is a little less steep on that axis. And so that's really what astigmatism is. It's just their cornea has kind of two different shapes and two different meridians. And so that will lead to light focusing at two different points on the retina. And so because there's two points that are focusing on the retina, then it creates blur, and that's why patients need their astigmatism corrected. Some can kind of work through and tolerate small amounts of astigmatism, but often, patients will want that corrected to some extent. And here's a little kind of flow chart summarizing what I've talked about, because I've said a lot of words. So astigmatism, we kind of define that. And then it branches into regular astigmatism and irregular astigmatism. And then under regular astigmatism, there are three kind of different things that we think about. We think of horizontal vertical, or like with the rule against the rule. And then we think of oblique and then bioblique. So with the rule astigmatism and against the rule is under this horizontal vertical. And so we'll talk a little bit about that here. So okay. So regular astigmatism, like I said, I kind of showed you in that flow chart, we'll have with the rule and against the rule. So with the rule, what that typically means is that the vertical meridian is steeper. And so that football here is a good example of with the rule. And that means that your cornea is more powerful vertically than it is horizontally. And it's, at 90 degrees traditionally. And this is a little bit more common. And so most patients as they're growing up, they're have like with the rule astigmatism versus against the rule astigmatism. And this is, sorry, I should clarify, the axis is different than meridian. So that's why the axis is saying 180 degrees, but the meridian is 90 degrees. So I'll show you kind of like a pentacam of that in just a bit. Against the rule astigmatism means that the horizontal meridian is steeper. So thinking of flipping a football on its tip. And like I said, the horizontal meridian is steeper, which means that the axis is at 90 degrees. And so this is common when patients are getting older. Their astigmatism tends to drift from with the rule to against the rule. And then oblique astigmatism is something kind of in between the two. So about 30 degrees from either the vertical or the horizontal meridian. So if you kind of think of something that's like a little bit um, uh, kind of like a diagonal, that's kind of oblique astigmatism there. And so when we write corneal astigmatism, we're really writing the power that each corneal meridian contributes. So just a reminder that the total power of the eye, the dioptric power of the eye is 60. And the cornea contributes about 2/3 of that versus the lens is a third. And when you look at, I think we've mentioned this before, but when we're looking at our like IOL calculations, usually, not always, but the lens that it's calling for is on kind of a normal eye. It's usually like in the 20 range because you're replacing the power that you've taken out from the lens. So again, that's 20 is a third of 60. And then when you're looking at Ks, they tend to be somewhere in like the 42, like 41 range. And again, that's the 2/3 of 60. 40 is coming from the cornea itself. And so here's kind of an example of how some Ks can be written. So it's saying 43 at 170 and then 44 at 80. And so the question here is, what kind of astigmatism is this? And what is the axis? And so this is with the rule because the steeper meridian is at 80, or just to simplify, it's at 90, so up and down. So again, up and down, that's with the rule. That's what most people traditionally have. And then the axis is associated with the flatter meridian. So the axis is like 170 if you're notating that in minus. And then for the second one, another way that people write Ks, this is 47.25, 40, and then it has another number, 46.75 at 35. And so this is asking, okay, well, what is this? What kind of astigmatism is this implying? And this would be oblique because the steeper is actually at the 125 meridian. So it would be 35 plus 90. That would give you the meridian furthest. And then the axis is associated with the flatter. So that's at 35. I'll just kind of go through that one more time. So here we have a meridian at 43, another one at 44. The 43 is at 170, so here. The 44 is at 80. 44 is steeper, it's a bigger number, which means it's stronger, is at 80. And so then we are saying that this is with the rule of astigmatism, but the axis is associated with the flatter meridian. So hopefully that can kind of help clarify a little bit of the notation. You might need to see it a couple of times for it to kind of like become more internalized, but hopefully this is a good primer for that. And then here are kind of the answers there. So keratometry, it's really the whole purpose is to measure corneal curvature. So again, to kind of get those numbers that we were just going through right now. And so the way that we obtain those numbers is by measuring things. And there's a lot of different ways that we can measure it. And there's kind of like pros and cons to think about each way. The oldest way to measure K values was manual, a manual like keratometer. And I personally have never seen one used. I've seen one collecting dust in a clinic one time, but I've never seen one used, but they're out there. And I will briefly walk through how to use it, but I can't say I'm an expert at using these manual keratometers. And it kind of works with this like prism doubling effect where it's reflecting an image, and then it uses a meniscus that needs to be kind of aligned to basically create like a value that you're looking at. It's not exactly like Goldman applanation, but it uses a similar-ish principle, that prism doubling. So a mire is formed, and then kind of that mire will be like proportional to the patient's corneal curvature. One drawback from this, one, it's time intensive. You need regular astigmatism to be able to measure this, or I guess even if you had irregular, you might not know because it's just kind of looking at like 2 points, and then it's dependent on the tear film. If patient's dry, it can kind of mess up your values. So these are the steps for getting these mires aligned on the manual keratometer. So step one, you're adjusting the focusing knob to kind of clear the mires and bring them into focus. And then step two is using the horizontal measuring drum and access barrel to determine the horizontal meridian here. And then step three, you're using the vertical measuring drum to determine the vertical meridian. And so here's kind of how it would look out of focus. And then as you kind of start turning those drums and getting into focus, it should look a little bit more like this. And here's some pictures of kind of those drums that you are using for a manual K. So an auto K, most auto refractors have this built in. So like when you print out that little receipt, you'll see the auto refraction for the right eye, and then you'll see that for the left eye. And then if you keep going down, you'll actually have some K values, so cornea values that kind of let you know how strong or how steep or how flat the cornea is. They can be expressed in two different ways, like radius of curvature versus diopters. Diopters is kind of like the more common way, but the way to convert between the two is just kind of doing, they're inversely proportional to each other. But kind of walking through this example. So here's the right eye and here's the left eye. So this, interestingly, not most, but more often the way I see it is like K1, K2. K1 will be the flat and K2 will be the steep. But this one actually doesn't do it that way. It's list H and B. So what the horizontal and the vertical. So it's not telling you which one is steep and flat. You kind of have to look at it and see. So horizontal is 42.5, vertical is 42. So you know that your horizontal meridian is the steeper one at 176. And so then it's listing the cylinder at minus 0.5 because it's the difference between the two. And the axis is at 86, which is the flatter meridian. And then this left one, a little bit of the opposite here. So the horizontal is 42.25, but the vertical is 42.75. So the vertical is stronger. That's with the rule of astigmatism, kind of what we've already talked about. And the meridian, the steeper, is at 79, but the axis is at 169. So the flatter meridian is the axis. All right. So some advantages. It's easy to obtain in clinic. It's less of a financial investment than some of these other machines that we'll kind of go through in just a moment here. But it only measures 3 millimeters of the cornea. It doesn't really tell you, again, if you have regular, irregular astigmatism. It's kind of choosing 2 points and making the assumption that it's regular, but it might not be. And it's, again, dependent on the tear film, and it's only accurate to about like 0.12 diopters. Placido disc is kind of a more advanced way to get keratometry values. And it uses, if you kind of look at a placido disc, you actually, it almost looks like a hypnosis machine because it has all these like circles that you're looking into. And it's reflecting that image on the cornea. And then something is reflected back to the machine, and that's what the machine picks up. And depending on how close those rings are, how far apart, it can make assumptions as to, okay, this is deeper here, this is flatter here. And then it has some type of algorithm and it assigns values to kind of how close or far apart those rings are. And so when Myers are closer together, it's steeper versus when the Myers are further apart, it tends to be flatter. And so you can kind of see like this keratoconus here. It almost looks like it's coming to a point. And so you know it's steeper down there at that bottom part versus the top part of the cornea looks like it's a little bit flatter based on how those Myers are hanging out there. And then the quality of the Myers can unfortunately also be impacted by the tear layer. So that's why we care a lot about dry eye. When we're doing these measurements, we want patients to have a good surface so that we feel like our data is reliable. So placido disc is, if you're only using placido disc, it's a type of topography, and it's only measuring the very front part of the cornea. So the cornea has a front surface and a back surface, and each of those have kind of some refractive power to them. The most of it comes from the front surface, though. And so it's only measuring that front surface. It's measuring the anterior curvature and the anterior elevation. And so it can be helpful. Some places only have topography. Sometimes it's just a little bit cheaper, or they just don't need kind of maybe all the information that a pentacam provides. And so this can be helpful for like screening kind of for some corneal diseases, contact lens fitting, and refractive surgery. Like I said, it's tear film dependent. And so those are some examples, ICE Atlas or NIDEC OPD are some examples of a topography machine, which again is just measuring the front part. Tomography, very similar words. Topography, I think of like topography as kind of like, I think that's the word that you use for like map making. And so when you're making a map, you're just surveying the land from the top. And so a topographer is, just kind of looking at the top. And then you think of the cornea, a topography machine is just looking at the very front surface. Versus a tomography machine is actually measuring the front and the back. So you can imagine that's a little bit more accurate, gives you some more information, can kind of detect disease a little bit earlier for certain conditions. And it uses scanning slit technology. So it's taking a bunch of like cross sections and kind of making a 3D model to be able to figure out what the anterior and posterior measurements are. The term that's kind of associated with tomography is Scheimpflug. I always mess that word up, so I'm sorry. But Scheimpflug based imaging and some like anterior segment OCT technology. And so, like I said, it measures the front and the back curvature and elevation, and it also can provide you some pachymetry. You can get pachymetry by kind of using like that handheld machine that like touches the cornea, but this is another way to obtain pachymetry data. The nice thing is it's not as dependent on a good tear film. It still will mess up your reliability if somebody has like a terrible tear film, but it's not as dependent as some of these other ways to measure cornea values that I've gone over. And kind of the most common tomographer that we think of is like Oculus Pentacam. So we'll kind of go through some maps here of Pentacam, and I think we'll be wrapped up shortly here. So this is kind of like the way to think about the axial map. That's the first one that you see. If you do like a 4-map printout, it's going to be the typically like upper left-hand corner. It's the power map. So it assumes changes of curvature are due to best fit sphere. And so it kind of smooths out some errors or irregularities. It's a good like first impression. Like if you're just trying to get a first impression of the cornea and get a general sense of what the cornea is doing, this is a great map to look at. It's pretty easy to interpret. And so this is a patient who has technically, I guess, with the rule astigmatism, that's starting to kind of like drift a little bit, but it's not quite oblique. So we would call this with the rule. And you can see that it's a little steeper on the top, but it is regular because you can kind of see it's doing this up and down motion versus if I had some green here and then maybe some green over here, well, that's not regular because it's now on another meridian. It should be sharing the same kind of like meridian path here. So it's okay if people don't know the answer, but just nice kind of to empower you a little in terms of like what you see on a Pentacam. This is a great example of post-myopic LASIK. And so when you're looking at this, traditionally, this is a better example of what like a cornea, I'll go back here, cornea kind of looks like. This little like yellow bump is maybe not as common, but if it was like green, that would be like more traditional, what you're used to seeing if somebody has a little bit of astigmatism. versus this, it's blue, which is telling me it's really flat in the center. And so your cornea really shouldn't be flat in the center and then steeper on the edges. That's a little bit of an unusual shape. The way that you achieve that shape is with postmyopic LASIK. So people who are myopic have steeper corneas because it's bending light and bringing it in front of the retina rather than on the retina. And so in order to kind of soften that process, we flatten out that cornea so that it doesn't bend light as well and kind of gets it onto your retina and focuses on your retina rather than in front of the retina. So this is a very good example of postmyopic LASIK on a pentacam. And then here's an example of the opposite, which is steeper in the middle and flatter on the edges. And so this is an example of post-hyperopic LASIK. So you're taking tissue on the edges to make the center cornea steeper so it can bring light and be a little bit stronger. So light is not focusing behind the retina, but it's focusing on the retina. And so you can kind of see if some patients don't remember if they've had refractive surgery. And so if you see kind of a pattern like this, it might make you say like, hey, do you remember if you've ever had LASIK? And they'll be like, oh yeah, now that you mention it. So it's just a good flag to pick up if you're doing pentacams for your clinic, then these are like nice things for you to look for. A tangential map. It's a little bit more of a detailed map. We don't use it like quite as often for like our four maps that we look at, but it's sensitive to like smaller changes. And it basically compiles like a radius of curvature over each point of the cornea, rather than doing like a best fit sphere. It's like giving you every kind of like almost like raw data and raw point. And my understanding is that can be really helpful for orthokeratology, like Dr. Nelson had kind of talked about. But and then it can also be good for like if somebody has had LASIK and you're not sure if it was a hyperopic versus a myopic LASIK, it actually can be a little bit helpful. If it looks kind of, it's hard to tell on the axial map, this is a good second map to look at and it can kind of give you that information. And then here's an elevation map, which will traditionally be on the top, like right side of that four map printout. And this is really just telling you the height of the cornea. It's not telling you power. It's not telling you strength. It's just an elevation. So it's saying it's this tall here. It's this short here. It's this tall here. And it is also a best fit sphere, or at least it kind of references that. And then, like I said, it just provides a contour of the anterior surface of the cornea. The warmer colors tend to indicate that something's closer to you, so it's more elevated versus cooler, it's that it's flatter. So a keratoconic patient has more elevation at the apex of their cone. And so this is someone who, if I didn't even see any of their other maps, I would be concerned that they have keratoconus. And so this is kind of like a clue that, hey, somebody might have some type of ectasia. The thickness map. So this is really pachymetry. What it's showing you is just telling you how thick is the cornea. So we talked about power. That's the axial map. We talked about elevations. That's that last map. And then now thickness map, which is how thick is the cornea at different spots. And so pachymetry can change based on certain conditions. So you can have like thinner central corneas in a patient who's had like maybe a refractive surgery or is keratoconic. My suspicion is that this patient probably has some keratoconus on this map that we're seeing because like their central like point is 374 versus these peripheral points are 563. It really shouldn't have that much of a difference between your central and peripheral cornea. And then thicker corneas can be more indicative of like edema or swelling of the cornea. And so we can follow thickness maps in Fuchs corneal dystrophy as a way to say like, oh, things are getting worse. They're getting a more edematous cornea over time. And maybe scars can also cause some thickening as well. That's kind of the main thing. I did want to go over one more thing that I think is helpful. Let me go back to this one. So just these little scales, every once in a while, it's like good to check to see kind of what are these scales and what is it based on. So there's a couple quick details that this is telling you. One, it's telling you that this is going in increments of 0.25 diopters. And so that's what it's using to like start that scale process. This is saying that it's looking at the curvature and then that this is a relative scale and it's going from 37 to 52. If you can make an adjustment to the scale so that's 10 to 90, and that's not really helpful because patients don't really have corneas that are 10 or 90. And so because you have such a large scale, it's really hard to interpret differences. And so having a scale that goes from 37 to 52 is much more useful because it will like 52 to us is very different than 37. So it's really nice to have the ability from like a color map to be able to tell, okay, this is different. And we would not be able to pick up those differences if we had a huge scale. And so kind of having a little bit more sensitivity on our scales is very helpful. And making it relative is really helpful because it'll, again, draw out patterns that are like concerning or interesting to us. And I thought I had a posterior elevation map, which I don't. But similar to kind of the front, it says elevation back. And if you have some like a posterior float, that can be concerning for like early keratoconus. That can be one of the earlier signs that we see. You can kind of use that as well for disease detection. That's everything. Any questions that I can help answer? I'm more than happy to answer. And I believe this is our last session. So
Yes, it is.
I really appreciate
We made it.
everybody.
Yeah, we made it to 12 weeks. Thank you so much, Dr. Morales. You
Yeah,
were here for it all, and we really appreciate the
yeah,
education and
of
your
course.
time. It's been a great series. I appreciate everyone that's been on. I just put into the chat the quiz link for today's session. So those of you who are seeking credit, please have all the quizzes for all the sessions you attended completed by April 8th, and then I will work on issuing you your credits to for you to then send on to either AOA or IJCAPO. Any questions for the doctors? I am seeing none. So
Okay,
thank you all. It's been a great series, and we'll see you all in 2027.
awesome. Thank you for all
Thank
your work. I really
Yes.
appreciate you.
Yeah, it's
Okay,
been great.
see you. Bye,
Bye.
everyone.